non-clinical. They are not involved at all directly. But without them, we can't run the centers. Administrators, facility managers, financial managers, and then they all will have to work as a team to produce these highly sensitive healthcare services. And then they have specific roles working towards a common goal every day with concrete boundaries. That's a team is, if you look at healthcare team. And generally, the team is a vehicle to work with among themselves, different professionals. They would work in terms of sharing their knowledge and then working, developing the skill, those are the behaviors, and of course the attitudes. And then this knowledge sharing, skill sharing, and changing the attitudes in working in a common culture, that would give interdependent performance in healthcare. What about a smart team? Now, if you are going to work in a smart world where we all have smartphones, right? Why don't we have a smart team in healthcare? So what can we do? What's the definition of smartness? It's very difficult to find a definition in smartness, but right across most of the healthcare centers, in acute care setting and chronic care setting, you would see more interprofessional work and the smart teams working to give patient care. Let's look at the gaps in patient care services and the issues with the ideologies and different goals, unequal power sharing and role overlap, and the communication. Let's look at the different ideologies and different goals. It's to do with caring patient or the curing patient. Our president also mentioned a little while ago regarding caring and curing. Who's going to cure the patient? Who's going to care the patient? So there's confusion in scope of work that they are supposed to do and their related objectives and goals. For example, discharging a diabetic patient who's recovered from a coma without giving a proper dietary advice. Whose role is that? Whose role is that? There's a confusion there. The unequal power and who has the advantage. Now, if you look at the healthcare system, the doctors are at the top of the food chain. And among them, the most senior and most older, more qualified doctor would head the team. And what about the others, nursing and allied healthcare professionals? What are their contribution to healthcare team? There's imbalance in power if you look at the healthcare setting right across the world. And it's more in the third world, second and third world like us. And for example, classic example is during the ward round, what is the contribution by a nurse or other allied healthcare professional in the ward round? What is the contribution of the house officer for that ward round? Barriers to communication is one of the key areas. So there are intra-professional, within the profession, communication barriers, and between the professionals, inter-professional barriers. That would definitely impact the direct patient care. And there are common methods that we have face-to-face communication, and we use the telephone a lot. And there's a dialogue through documentation. That's the most vital and common healthcare way of doing communication. Case notes, the most vital or document that we use for communication. And what is the clarity of these? And I can remember when I was a deputy director of a teaching hospital, I did a small study because our medical record department was piling up with so much documents. I wanted to remove some. And then during the process, we've looked at the writing and the notes, and it was horrible to tell you how nobody could even read the handwriting, and the clarity was enormously not acceptable at all. And the meaning of certain words that we use, and what are the standards of these notes or the directions that we have given, and the language, acronyms and all that we use, that also comes as a contribution to communication barriers. Then the role overlap. Who's going to do what? Right? There are professional roles. As a profession, we do have professional roles. And then at that particular process, there are functional roles a nurse or a doctor or a house officer or a SHO, senior officer should do. And then who's going to take the responsibility? Who is accountable for this whole procedure? Now all that confusion will lead down to breakdown in communication. For example, the wheelchair prescribed by the physiotherapist for a patient with disability in the hospital versus the occupational therapist would have a different point of view. It would hinder the mobility and her scope of work. Then let's look at the need for a multidisciplinary training approach. It's essential that, as you can see, all these would contribute to hindrance of giving precise precision and also the accuracy of healthcare delivery. Typically, the healthcare training could be done at the basic training level. That's at either the medical school or a nursing school or during the basic training or post-basic training. So sometimes we call it as in-service training. So those models, both models are available. Currently, mostly we do for a specific professional group. Now, if you look at training, what we do is we have a learner profile on one side. We have a learner who's coming into the system, and then we have a job description of that particular person, either the doctor or a nurse or a physiotherapist or the allied health science professionals, job description. So during the training program, what we do is we bridge the learner profile to the professional job description. That's what we do during a training program typically. And then unfortunately, whilst we are training, we give them a unique value set, and then we create a different cultures and different work ethics. And all these people will have to ultimately work as a team, mind you. Right? So what can we do to avoid these kind of differences in value sets, cultures, and work ethics? Well, if you look at the world, they'll use collaborative training where they study together common modules. Doctors, nurses, and the others would sit in one same platform and study. And in addition to that, they also train there are specific modules on multidisciplinary training. I've looked at a local scenario. I haven't seen any modules on collaborative training or either multidisciplinary modules. We managed to get IIHs about 10 years ago inculcated. I think currently we are the only organization which facilitates these two methods of training. So where can we start this? This is a very complicated affair. Let's look at this in a very simplistic way. First, we'll have to gather what is happening out there, evidence-based approach. We need to do research area. First, we'll have to look at the process, how each unit, what are the clinical processes which are done, and the structure of the human resource in that particular unit, how it is formed. And then each one of them, what are their contribution to that process. And then we could look at a methodology called process analysis of this, breaking down into the clinical process into measurable divisions where you can study individually. Then look at scope definitions currently available for each contribution of each staff member, a nurse or a doctor, and what are their job descriptions at the moment. Then we know, looking at the process and then current job descriptions, and then we can really go do an excellent training need analysis. Minute we do that, and we can brush this up with things like professional surveys. What do the doctors would think? What the nurse would think about this particular process? And the patient surveys. The patient would see this totally differently, independently, because they would see how the whole healthcare team would work. And then, of course, the case-based studies, our mortality morbidity reports, or the reflective reports, those all will give us a nice insight, very good insight to the currently what's happening out there. Then the policies. Then we can develop policies in order to fill this gap which is identified by research. We could look at upgrading our clinical protocols, professional standards, organizational and legal and ethical standards, and the policies. And of course, looking at the inculcating training at the very beginning, at the basic training, as well as the continuous professional development. Then these policies should achieve flexible interprofessional practice that are not constrained by the professional boundaries. That's a very important point to look at. So what are the contributors? Now, as health administrators, we could take the leadership role because we could create a nice sustainable platform for all these professions to work in tandem. Where between the professionals, there's goodwill among the staff, and as well as that will contribute to the goodness to the staff as well. These interprofessional workshops in the later stages of the basic training is of importance. And then there's promoting the shares philosophy of a team, what a team could do by education and training. Then, of course, moving from unidisciplinary post-registration training to collaborative training and education. Once we do that, then that will not stop the whole process going. For each year, we have to do monitoring. A part of the looking at their job. Then the departmental meetings and the ward round. That's the basic collaboration that we do every day. And with administrators and the quality officers, of course, can contribute to monitoring of the whole process. Then evaluation is important. Reviews, periodic review, case studies, reflections, and interprofessional team research. This is an ongoing process in order to improve the quality of care and the precision of care. So with this, finally, we could achieve our SMART team goals, improving the patient outcomes, reducing the length of stay. That will definitely save loads of cost, and then increase job satisfaction. We can reduce the turnover of our healthcare professional from the healthcare team, and then improve teamwork. With these things, with these points, I would wind up, and I think the future, this ongoing process, and each of us has an excellent opportunity to work together. And also for the young researchers, I think this is a wonderful area to look at and do research. Thank you very much.
And I would like to invite her to deliver her speech about training nurses in multidisciplinary settings. Ms. Glenda Whiting, the stage is yours.
Good morning, everybody. Firstly, thank you very much for inviting me to speak. It's a very nice time to leave Australia because it's winter, so it's nice to come here where the weather's warm. And thank you very much to all of my friends at IIHS for inviting me again. I think this is my 5th visit, we think, yes? So thank you very much. As mentioned, I'm a registered nurse and midwife, and I want to give you, I guess, a little bit more about multidisciplinary healthcare as it has progressed in Australia. I wouldn't say that everything's perfect, and I don't know that we have the best model, but I'd like, and really if you read the last couple of lines of that, is that we want the best possible outcome for our patient. So it's about all of us doing what we all do well for a really good outcome for our patients. And as Dr. Kisili has already mentioned, there are improved health outcomes and enhanced satisfaction for the clients or patients, much more efficient use of resources, and it actually enhances your job as well. If your patient has a good outcome and is happy and healthy and can go home and live a fulfilled life, you feel good about that yourself. So the fact that you've contributed that can help as well. So just some background from the Australian College of Nursing, which is the peak body for nurses in Australia. We all know that the demand for healthcare is actually exceeding the supply. So there's more people needing care than we have doctors, nurses, physios, pharmacists, podiatrists, whatever it might be to do that. The other thing certainly in the West is that the population and the health workforce is getting older. As Miriam kindly pointed out, I've been a nurse for 35 years. I'm not going to be a nurse for another 35 years. My career is winding down. Somebody has to come along and replace me. And I will go from being the person delivering care to the person needing care. So I want the next generation coming through to be well trained so that they can look after me well. We are very much in a consumer-led life. So even in exactly how things happen, they see that and want that. So that gap around all of that expectation and the ageing thing is really apparent in the healthcare system. And so in Australia, we've really moved to looking at some of what we call primary healthcare models so that we can try and get things where people are actually kept out of hospital and things are managed more in the community and people are much more aware of things that they can do to enhance their health so perhaps they don't have to come to hospital and have other treatments or surgeries done. So that integrated primary health care is seen as being what will replace that traditional really acute model of care. Lots of reform has taken place. People don't stay in hospital very long now. Lots of things are done by day surgery. Even when you have a baby, if you come to hospital and have a baby, most people, if they have a normal delivery and everything's well, they go home within 12 hours. They don't stay in the hospital. When I was born, my mother stayed in for a week. They weren't allowed to get out of bed for 5 days. But that's all changed. So there's hospital in the home, there's telehealth, and we also have nurse-led clinics. I'm sure you're aware that Australia is a really large country and some people live in quite areas where they don't have access. The way that we're delivering, last dot point there, the traditional ways that we do things don't meet the requirements of the 21st century, so we need to make changes to doing that. So just some examples for you about primary healthcare. You can see that there's that circle there, so it's meaning that everything flows together. It's about managing health promotion, preventing illnesses. Lots of different professionals become involved in doing that. It's about safety and quality, and it's also about prevention and intervention before you get to the worst case scenario part of it. And as you can see there, it talks about dental, nutrition, behavioural health literacy, some of the things that were mentioned in the previous presentation. From our point of view, as far as educating the health workforce, we need to make sure that they're educated socially, professionally and technically to work as part of that team. And those are those points there that are really important to encompass in today's education. And it doesn't matter what discipline you're in. You're learning nursing, that the next generation of people that are coming through any sort of health program will hopefully have that cooperative and collaborative approach, and they'll be the people that make the change. They won't come out and allow things to continue as they have been, where there isn't that collaborative approach between people, and it ends up showing that right throughout, they're the ones that can make the difference. So we need to integrate that in the undergraduate, in the postgraduate, in the clinical education, all of those areas. And as you can see by that, each person in that picture is holding a piece of a jigsaw and they all fit together somehow. And not all the time do you need all the pieces, but they need to be able to fit together, and we all need to know and understand each other's education and training and the capacity that you have to contribute. Some of the problems, always money, isn't it? So in Australia, unfortunately, the current healthcare system doesn't really help multidisciplinary care because not everybody that's part of the team fits into part of the funding model. So as nurses, while we do have some nurse practitioners who are independent practicing nurses, and they can have what we call a provider number and therefore get money for but it actually doesn't work very well in the community because in every community there isn't a doctor in Australia, especially in the remote areas. Some people never see a physio. Some people have a dentist visit every 6 months. It doesn't always function very well. So there's a realisation that we really need to make sure that there's funding for all of those things. And again, that doesn't occur from us. That's a government thing that needs to be done. So some of the solutions that I'm going to suggest to you are that we encourage that primary healthcare focus within all education and training programs, and that people get a really broad idea about healthcare delivery, not just about your own discipline, about other areas. As Dr. Kithiri said, in some areas we've been integrating some of the teaching, so particularly the subjects that all disciplines learn, and the one that comes to mind is the anatomy and physiology, so how the body works. In some universities in Australia, the medical students, the podiatry students, the nursing students, the paramedic students all sit in the same classes for the same anatomy and physiology lectures, because it's the same information that they're getting in that very fundamental learning, and they do then start to develop friendships with people in other disciplines and perhaps get a better understanding of what's going on. So as it says there, all of those things must have a high priority in that transdisciplinary area. The other thing that we can do is to make sure that the people who are actually working come into the academic area and assist with lecturing and information. It shouldn't be two separate models, that there's academic people and clinical people. If you can get the people working clinically to come in and be teaching and giving their information about what it's like out there in the workforce, that can enhance that as well. So we call that a shared teaching model, so that I go and work in the hospital and my colleagues who are hospital-based come and give some lectures to the nursing students about anything. Could be process, could be how to do something, could be just how the hospital's working. So that shared model also helps we have that bit of a problem about that clinical mentoring and leadership role. So when our students go on placement in the hospital, it's often hard to find the right people to mentor them and to work with them. You know, you remember that the first day that you started work in the ward and you're nervous and you're scared and everything you ever learnt you've forgotten and you hope nobody asks you a question because you won't be able to answer it. What you really need was a friend with you who would help you, and when you were confused or having a moment, they would encourage you. It's very hard to find those people, so sometimes having those people come into the educational area and see how the education system works, then when the student goes on placement, there's someone they recognise and somebody that they know they can go up to and ask for help or ask a question. So that's that shared model. Really, because I'm from that educational basis, education must be organised and prepared in a very sustainable way, and therefore you can have those dual roles of people being academic and clinicians as well. Ongoing financial and professional support to courses and other professional activities to maintain that motivation. So you must know as professionals that the day that you finish your basic training isn't the last day that you ever learnt anything. You continue to learn throughout your life and career, and I can certainly tell you in the 35 years that I've been a midwife, a lot of things have changed. Babies still come out the same way, but there's a lot more technical things that go on than when I first trained. So other solutions, so we need that transdisciplinary learning to be a full part of the educational socialisation so that everybody relates to each other and knows what they did. Importantly, that transdisciplinary education needs to be horizontal and vertical, so you learn up and across from other people, learn from people who know above you as well. The other thing that we try to do is that some of those clinical placements get organised where students from different disciplines go on clinical placement to the same place together. So while you might be there as a nursing student, there might be physio students there as well. Not only does that help that there's a lot of students around, but you're also sharing that learning that you're doing through seeing what the colleagues perhaps that you've worked with. And certainly within the educational environment, trying to create case studies based around that multidisciplinary area and healthcare team area, and having other disciplines come in and assist with that. We talk a lot about problem-based learning and experiential teaching. where once the students learn some basic skills that you give them a problem to solve, so you give them a case study, make it real world, make it about what might be happening in the environment they're going to go in. And then in this case, in the primary healthcare model, talking about what would you do then if you weren't in the hospital or you weren't close to a hospital? How would that be managed if the closest medical care was 2 hours away? Or in Australia, it might be the flying doctor comes. So you've got to wait for the plane to come with the nurse and the doctor. What do you do in between? How do you manage that? And definitely all those problem-based principles abound. You develop that inquiry, you make decisions, you evidence-based practice what you've learnt, you collaborate, all of those things that work. And it also encourages you to continue learning and have that thirst for knowledge. So I've mentioned about the clinical mentoring and how critical that is for the clinical component, that combination of the academic and the clinical teaching staff that assist in that transition. Lots of people find that if you study at university, or in our case in Australia in the vet sector, and you're supported and you're in a skills lab and then you go out into the real world with real people, it can be quite hard to take that step, and that's the scary part. So we can try and perhaps have a smoother transition between that by having some of those clinical staff assist us in our teaching. So combined multidisciplinary and academic clinical teaching and learning model creates that foundation to promote that competency-based education. And finally, just the idea that that transdisciplinary interactions in the working environment encourages all that teamwork, achieve the common purpose of producing better health outcomes. We can all stand here as academics and tell you what we think we should teach and how we should do it, but the final result should be that there's better outcomes for the patients and there's good outcomes, and we get professional confidence and satisfaction that motivates us as well. Thank you.
Thank you, Ms. Glenda. Our next distinguished speaker for the morning is Dr. Leanne Bodkin. I invite the chairperson, Dr. Sankar Randani Kumara, to introduce Dr. Bodkin.
Thank you very much. Thank you especially for making our lives easy by doing part of our job as well. And it's a privilege to introduce Dr. Leanne Bodkin. She has graduated from Manchester Medical School during an innovative period in curriculum reforms in late 90s, living with an interest in medical education. She's pursued this as a career, working at medical education units of the University of Edinburgh, the University of Birmingham, and she's now a clinical lecturer at the University of Aberdeen, working in the undergraduate medical program as a member of the Foundations of Clinical Method team. She has an interest in interdisciplinary working and fostering collaborations, and lead 2 areas of the curriculum that demonstrate this: interprofessional learning, that is IPL, and the medical humanities student selected components, SSC. As IPL lead, she has worked in collaboration with colleagues within the University of Aberdeen and their partners, Robert Gordon University, to develop a realistic and relevant IPL program with opportunities across all learning environments. Her aim is to inspire health and social care students to foster knowledge, skills, attitudes, and behavior for effective collaborative working, and to deliver person-centered, safe, and effective high-quality care. Dr. Leanne Bodkin, the stage is yours.
Good morning. So firstly, let me thank you very much for inviting me to come to this very important occasion to speak about interprofessional learning. Thank you to the SLMA and to IIHS for inviting me, and thank you very much for bringing me to this fantastic country that you have. I've been asked to really give a medical education perspective on interprofessional learning, and I will draw on my own experience in Aberdeen, where, as was mentioned there, we have a collaboration that enables us to provide an interprofessional learning programme for our undergraduate students. I'm firstly going to explain why I'm saying interprofessional rather than multidisciplinary. In the research in this area, there are lots of different terms used. So you hear multidisciplinary, multi-professional, interprofessional, interdisciplinary, kind of used interchangeably, but often with confusion over what's meant. So some people think it means the number of professions involved. Other people think it's to do with the environment that it's taking place. So my point of view, I'm going to use the analogy of a map. So these are the Orkney Islands. This is north of Scotland. Off the top of Scotland is the Orkney Islands. This is an archipelago of about 70 islands, and each one has its own identity. So we have Sanday, which by its name you can see is well known for its sandy beaches, a bit like the beautiful beaches here in Sri Lanka. We have Hoy, which is a very rocky, rugged landscape and has the famous Old Man of Hoy sea stack there. And then we have North Ronaldsay that has seaweed-eating sheep. So each one has a different identity and has a different purpose. The same with the disciplines. So each discipline has its own contribution to make to the care of the patient. But where's the patient in this analogy? Well, the patient is the ferry that's bouncing between all these different disciplines, getting each component of care from a different place. But I think that suggests a kind of disjointed approach to care. So I prefer interprofessional. So rather than the map analogy we might use, which you've seen in other presentations, but perhaps in a different way, the analogy of a jigsaw. The research around teamwork and multidisciplinary or collaborative care has focused very much on what happens between us, the connections, the interactions, what goes on between us, as opposed to what we are ourselves, but those interactions. And that's where the evidence, when there are failures, where we mentioned where there might be failures in patient safety, it's usually down to poor cohesion, poor understanding of shared goals, poor communication is a big one. So actually when we come together and we work collaboratively, it's what happens at those junctures. It's what happens when we interact with each other. And if we come together and work well collaboratively, then we create a picture of that patient together, and we have a shared understanding of that patient and their care and the journey that they're undergoing. So that's the vision that I want to have in your head. I've mentioned collaboration a few times, as have previous speakers. So this is just one definition that you might use. This is a Canadian researcher that defined collaboration in this way in their work. So it's an interprofessional process of communication, decision-making that enables our separate as well as our shared knowledge and skills as healthcare providers to work synergistically, to work together, to influence the way that the client and the patient is cared for, but also, as Dr. Githiri spoke about, how those health services are provided. So actually at all levels, not just at the individual patient, but throughout the healthcare system, how that is all provided. So I'm speaking about interprofessional learning, so I need a definition for that as well. This is the Centre for the Advancement of Interprofessional Education, which is an organisation promoting interprofessional learning. And this is their definition. So when a student or a member of two or more professions learn with, from and about each other to improve collaboration and the quality of care. So just hold that in your minds when I speak, and think about experiences that you maybe have had where you have been in that position. It's a really common experience, and perhaps we don't value it as much as we should. But as has been expanded on a lot already, this is a global agenda, thinking about collaborative practice, And this is from the WHO's document on the framework for action on interprofessional education and collaborative practice. And this was a quote from a student leader, and I think it's quite insightful about how much education can impact in the world and change and innovate. And what this student has, I will let you read it yourselves, what this student has pointed out is that by changing our approach to education, by changing the culture of healthcare education, we are actually really talking about a changer in the culture and practice of healthcare. So it can be quite transformative. Okay, a little caveat now. My title that I was asked to speak about was the evidence for interprofessional learning. And I have to be honest and upfront that there is, the evidence base is not as robust in some areas as we would like it to be. If we think about Kirkpatrick's levels of evaluation, so how we evaluate an intervention, yes, we can get positive feedback from people saying, yes, we really enjoyed that intervention. But what did they get from a learning point of view? And usually the literature in this area is looking at the changes to attitudes as opposed to the changes to knowledge and skills. And what we have are quite a lot of tools that have been developed to establish people's attitudes and how they have changed as a result of that intervention. But often this is self-reported attitudinal changes and short-term effects, so kind of before and after, but maybe not looking forward. And then in Kirkpatrick's levels, we think about the changes to behaviour and what's they really done. Have they applied their learning to their practice, and has it changed their behaviour? And there is limited evidence on whether that can be seen, and also it's a very complex area, so to attribute causality to having an intervention into interprofessional learning, having the effect in practice, is very difficult to do. And as was mentioned, we want our outcomes are to improve patient outcomes, but actually the impact of interprofessional learning, there hasn't actually been the research yet to robustly say that this intervention has this outcome, that we improve the impact, we improve patient outcomes, we improve staff morale and turnover, we reduce errors and complaints. So there is a degree of faith that we have to go forward with to say that it seems intuitive that to improve collaborative practice, we introduce collaborative practice and collaborative learning through training, but there isn't the robust evidence. So I will refer to some evidence, but some of it is applied to this situation rather than directly from it. So as Dr. Kissiri said, this is probably quite a ripe area for research, so think on that as well. So I'm just going to speak a little bit now about interprofessional learning. The why has really been covered, so I'm going to speak a little about when we perhaps would do this, how we might do this, and what we might do. And in order to do that, I'm going to use this rather complex diagram. I'm not going to speak about all of this, but this is just to give you a framework, and this is a framework developed by some writers, Reeves et al., to describe the complexity of interprofessional learning and interprofessional teamwork and the various factors that can impact on it, and these are based in these 4 domains. And the majority of what I'm going to speak about really is in this relational domain. Other aspects may pop up, but particularly context and organisation, that's something that is so particular to each individual situation and culture, and not even, I don't mean that in terms of Sri Lanka versus the UK versus Australia, but actually within a hospital, within a department, when you get right down, there are microcultures, and much research has been done that you cannot apply the same approach to each individual department even, because each one has its own character and it has its own functioning, and you have to take that into consideration. So it's not easy to generalise in that sense. So starting with the question of when. Do we start giving interprofessional learning opportunities when we have embryonic professionals, when they start in their undergraduate career? Is that when we start it? Or do we leave it until they're in the real world and it makes sense and we apply it at that point? So in the undergraduate world, which is the area that I predominantly work in Aberdeen, we have a few things that we need to consider. one of the factors in that framework is socialisation. So talking about professional socialisation. So when you come into a profession, you develop the values, the beliefs, the behaviours that go with that profession. But that's not something actually that happens just in training. We already have started with that before we've even entered into that career. We've gathered that cultural understanding, what it means to be in that profession. It's why we've chosen to come into that profession. So that socialisation practice has already started, but it goes on during training. And if we wait until we have had that identity develop, it's maybe quite difficult to move people at that point. But also when you're just beginning to understand what it is to be a nurse, to be a doctor, to be a physio, to be a pharmacist, it can be quite challenging to have someone question that and discuss their professional identity in relation to yours. And it can make people close in and become quite inward-looking. And so actually it can be quite difficult to do that at an undergraduate level when people are just forming that identity and understanding what it means for them. But there is an opportunity with the stereotypical view. So we all come in and we have ideas of what it means to be a member of whatever profession. And as I say, that comes from culture, etc. And that's not to say that these are always negative. They may be positive. So it may be that to be a nurse is to be caring and compassionate. To be a doctor is to be knowledgeable and have answers for the patient. So they may be positive, but they may be negative. So it may be a pharmacist is only interested in drugs and not in the patient, or a nurse doesn't make any decisions. So they could be negative or they could be positive, but we hold those stereotypical views and we apply them to everybody in that profession. So there is a potential, if you get in early and you role model positive behaviours, that you meet someone from another profession, from an out group, not your group, from an out group, and you see them modelling different behaviour, and you say, oh, okay, maybe that profession is caring, and I didn't realise that before. And the beauty with the psychological process of stereotyping is that you then apply that to all members of that profession. So you see that change and then you apply it. So it can have quite profound effects. So what we say to our students is it's about making connections. So we get them together early on, and in order to learn, we make connections, and our neural connections are reinforced by having that positive learning experience. And so what we want to do is develop the right connections early on and improve those. A couple of other things about the undergraduate environment. Obviously, this is the time that is set aside for learning. This is when we are training people. As was said by the previous speaker, that's where we're taking them from the idea of being that professional to actually creating a practicing professional at the end. So this is the time for learning. So this should be a good time to bring people together for interprofessional learning. One of the problems, of course, is that we have to align curricula. The logistics are quite complex to get people together to create opportunities like this, but they can be incredibly valuable. The other stumbling block is that at this point in the undergraduate arena, people are not yet practicing. So we're really only able to talk about things in a theoretical sense or in simulation. They're not yet in practice. So that's the downside to doing that. And that sometimes can be problematic for people to engage because they don't quite understand it yet. They're not there yet in their own training to take this on board. But again, the way we portray this to our students, and we have students from 10 professions coming together in Aberdeen in the first term of their first year to make sense of this. And they come together and we ask them to think about building relationships. That takes time, so we need to build relationships. But this doesn't stop undergraduately, this needs to go on postgraduately. So as I said, that can be problematic with a formed professional identity, but actually at that point, we may be more robust and able to have those discussions because we've formed our identity more strongly. And our stereotypical views may be improved because we've worked with a wider number of people, we've had opportunities to adapt our views of different professions. But time to have dedicated time for interprofessional learning postgraduately can be problematic when the focus then is on patient care and healthcare delivery. So making time for that. My colleague will speak about how in practice time is made for that. And Perhaps it's not making new time, it's how we use the time that's different. But one of the positive things about the postgraduate arena is that we have the agenda of patient safety as a driver pushing us to come together to improve collaborative practice. So I will skip through how and what quite quickly now. Again, predominantly on the relational factors. These are the relational factors I'm covering, particularly on team composition and the processes. So how are we going to do this? Well, we're going to get together groups. If we get together large groups, there is a danger that there will be subgroups formed, and they might be on professional lines. So we need to get a group size that will actually enable discussions. We'll have enough members there to represent the appropriate, authentic groups involved in that particular case or scenario. And we need to ensure that maybe professions where there are smaller numbers do not feel overwhelmed. So we don't have a group of 5 doctors, 4 nurses and 1 occupational therapist, because that can be really overpowering. And also to expect those individuals to be able to represent their profession, particularly at the early stages, can be really difficult. So not putting people in a position that makes it very difficult for them as a learner. Smaller groups, the problem then is that you can have overemphasis from individuals, and in an interprofessional setting, that might mean from an individual profession. So around about 8 to 10 from educational research would be the place to go. And maybe not to have all professions. So as I say, we have an event that involves all the professions that we have access to healthcare students of. And that's really an introductory. We have similar values, thinking about professional values, but it wouldn't be ideal. So for example, having a patient scenario of a patient being discharged home after a fractured hip. Yes, physiotherapy might be involved in that, occupational therapy, nursing, medicine, but if we put a midwife in there, it would make no sense. So it has to be authentic and real to practice. So there will be opportunities where we should focus on limited professions. Where are we going to do this? We need to do this everywhere. We need to do it in the classroom, where it's case-based and we can control the environment, control the information, ensure the appropriate learning is gained from that experience. And we need to do it in practice, as was mentioned in Australia, have opportunities for students to come together in practice. And then there's the in-between place of simulation. And that's a really key area where we cover interprofessional learning. And what do we do in this situation? Well, most importantly is it needs to be active. It needs to be active engagement, where people are engaged in the conversations, engaged in the content, so it needs to be authentic and meaningful to them. So simulation is a really good way of doing that. But also we need to take some time and we need to reflect on that experience and have debriefs and reflection as part of interprofessional learning. And some professions have that as part of their learning already. Others that's relatively new, but it really is key to interprofessional learning that we have that. And I've mentioned mainly cases, perhaps, is the way that we do it. So putting things in a clinical context, and that is really valuable. But again, if you're not yet holding that knowledge and skills to act as that profession in that context, that can be really difficult. So there is a place for generic team building sort of activities that are not around clinical work, that actually could be something that everyone is on an even playing field, that their hierarchies maybe can be broken down, and that can be really valuable. And my last point really is to flag up some of the issues that can be raised. So a lot of interprofessional learning talks about the ideal situation. We can say this is how it would work, this is what a best team would look like, and we can be very positive about it. But we have to also be open
participants to please switch your phone back to silent during the next half of the proceedings. Now I would like to invite back our chairpersons, Dr. Nihal De Silva and Dr. Sankar Randhani Kumara, back up on stage. At this time, I also invite Dr. Nihal De Silva to share a few words and to introduce our next speaker.
Good morning and welcome again to everybody here. I hope you enjoyed your little tea break. We are about half an hour to 45 minutes behind time. However, I hope you are finding the morning helpful or productive or entertaining or all of the above. In the interest of time, my 4-hour lecture is going to be reduced to 4 minutes, and I hope I can get some ideas across at least before we have our next guest speaker. In the evolution of clinical medicine, there was a time when people sought a physician's help when the disease was so far gone that signs and symptoms were just good enough to make a definitive diagnosis. No testing was necessary, and treatment was mostly futile. Today, it is quite the opposite. We look for biomarkers, etc., by testing to pick up illnesses long before they have damaged us. In fact, it has become an issue as to whether we should get this information very early in life, in infancy, or even before birth, prenatally, as this would influence attitudes towards the future. These investigations are usually done under the caption of laboratory medicine, with body specimens, mostly blood, urine, and biopsy specimens. And these things kind of detach the patient from the physician and makes the patient a specimen of sorts, with an assigned number nowadays to make sure that the information is accurately stored and transferred, especially with the use of computers. Now, in this process, are we missing or losing the forest for the trees? That's an old English proverb, losing the forest for the trees. Now, today in Western countries, it is fashionable and even politically correct to refer to patients who are people as customers or clients. This implies a commercial aspect in the interaction between the doctor, the system, and the patient, and an image that probably most doctors find distasteful but cannot avoid. In modern allopathic medicine, the patient gets compartmentalized, and the standard approach focuses only on a single or maybe 2 or 3 compartments. And although this has produced dramatic results, it also has changed the traditional respect given to the doctor-patient relationship, and it leads to a more business-like encounter. And this is sometimes exaggerated by third-party payers. In the holistic approach that we are talking about today, not only the physical health, but also the mental, emotional and spiritual health of the patient are considered. This wide approach is at odds with the present narrow focus, as this approach has to accommodate lifestyle management, exercise, nutrition, physiotherapy, prosthesis maybe, psychologists, occupational therapists, stress management people, health education, social services, spirituality, and so on. So this is beyond the management capacity of a single person, the doctor, and has necessitated the integration of support services that have emerged as specialties of their own. The doctor then only acts as a coordinator, or else the manager or a conductor of an orchestra. Each instrument of the orchestra is essential for the best sound, and as such, their importance has to be recognized, appreciated, and given equal respect. The doctor is not all powerful as he was once, and he is only the captain of a team maybe, and sometimes even a lesser player in the team. These are new ideas we need to get accustomed to. The process of mobilizing other professionals and even laypersons to support recovery from illness is the multidisciplinary approach. It may have appeared on the scene quite stealthily or surreptitiously, instigated maybe by the public, by the patient, as they resorted to complementary or alternative medicine treatments for more satisfying emotional or spiritual comfort. We in the medical profession have to accept the fact that such an approach has proven to be more effective overall, although maybe hard data are not yet evident, as one of our speakers said, but we have seen that it does result in better outcomes. And this also has satisfaction for the people who are supplying the support services. It also helps in using the resources we have more efficiently. And therefore, we should all embrace any approach for the benefit of the unwell. The increasing impact of non-communicable diseases and increasing aging populations has further made this approach imperative. We should be on guard, however, not to legitimize quackery. Today's symposium hopefully will shed a little bit of light on different aspects of this approach. And with that, I would like to introduce our next speaker, Mr. Peter Bodkin. We in Sri Lanka, I guess, probably would like to call him doctor. In their culture, surgeons are called Mr., if I'm not mistaken. It's like in Australia, pilots of an airplane are called drivers, which I thought was terrible. But there we are. So, Mr. Peter Bodkin is a consultant neurosurgeon from the Aberdeen Royal Infirmary in UK. He has been a consultant neurosurgeon in Aberdeen since 2014, graduated from Manchester University in 2000 and trained mainly in Edinburgh and Aberdeen. His choice of specialty was heavily influenced by an elective he did in neurosurgery in Mumbai as a student. So we have had some influence on him from the East. Huh? Okay. He has close ties with Aberdeen Medical School, where he is regularly involved in teaching and research. He set up the national teaching program for neurological trainees in Scotland. And he's a person who sets exams for the for Royal College of Surgeons in neurosurgery. And he also has preparatory courses in Aberdeen for the same examination, the Viva part of it, to become a fellow of the Royal College of Surgeons. Mr. Peter Bodkin, I invite you to the podium.
Thank you, Mr. Chairman, for a very nice introduction. It's a pleasure and a privilege to come to Sri Lanka and speak to you today. See if I can get this working. As has been said, I work as a consultant neurosurgeon in Aberdeen. So this is our hospital. I don't know if you can you see the pointer? Not really? Anyway, so this is our hospital in Aberdeen, a teaching hospital, about 1,000 beds, large for UK standards, but not quite so compared to Sri Lankan standards. The medical school is off to the left of the picture. It's on the same campus, as is the children's hospital, which is on the right. You can just see the top of it here. And so this picture illustrates Aberdeen on a good day. You can see the blue skies and the glittering North Sea. And it is a fair representation, but it is cold in Aberdeen. So the average temperature is about 8 degrees, and we very frequently get to below 0 in the winter. So when Mrs. Bodkin came home one day to say that she'd been invited to Sri Lanka to speak about interprofessional working, I assumed that my role would be supporting from the beach. But then she told me that, in fact, I had to do some work. I had to speak about interprofessional practices from my point of view, from a practical point of view. And I had to think about things. So obviously, I'm not an academic from the medical school, and I had to really think, what am I going to speak about? And the first thing that I looked at was my weekly timetable. And I thought, well, actually, on a Thursday morning, we have multidisciplinary team meetings. We get together with the spine orthopedic surgeons, the radiologists, and talk about spine cases. We also have a neuro-oncology MDT going through cases with radiology and neuro-oncology. So I guess that's multidisciplinary, interprofessional working. And then I thought about things again. So we have a morning meeting where the nurses come, and the physiotherapists, and the speech and language therapists, and the pharmacists come. So in fact, the morning meetings, the handover meetings, again, that's interprofessional working. And in fact, theatre, obviously that works with the anaesthetists and the scrub nurses and so on, so that's interprofessional. Well, clinic, so you've got a nurse there, maybe take some bloods, you've got a receptionist that you work with. Admin, in fact, admin, I sit down with my secretary, and a lot of the time is actually corresponding with other professions, so that's interprofessional working. And I guess teaching medical students is also working with other professionals. So in fact, my whole week is really interprofessional working. So I had to think about what to prepare for today, and again, Mrs. Bodkin provided a very nice book for me to read by Reeves et al. I'd encourage you to look it up. And I went through a few chapters, and it talked about educational versus practice versus organizational interventions. So these are interventions that are aiming to improve interprofessional care. It talked about relational, processual, organizational, contextual type of interventions, direct and indirect. And so it all got a little bit technical and dry and difficult to read. But I found a table which went through all these interventions, trying to improve interprofessional management. And I don't think you can see the writing there, but I recognized a lot of these interventions we had actually done in our department in Aberdeen. So I thought about how I could illustrate these in this lecture today. And I thought that the best way would be to go through a patient's journey, a single, fairly straightforward example of the patients that we see in our department. And so this is Mr. S. So he's in his 40s. He comes from the Orkneys, the little islands off the top of Scotland. And he presents with a seizure, his first seizure. He wakes up, he's admitted to the local hospital, and he goes on and has some imaging. And so this is an MRI scan, an axial MRI scan. And, oops, sorry. We can see a lesion in the left frontal lobe, the white area that you can see on the right side, which doesn't enhance with contrast. It's probably a low-grade tumor. It's in a bit of a tricky area. So the motor cortex, the primary motor cortex, is just right behind it. And the speech area, so Broca's area, is just below it. So it's in a particularly eloquent area. And in general, for these kind of tumors, we would tend to offer an awake craniotomy to keep the patient awake whilst we debulk the tumor. So what I'll do is just to go through that patient's progress and the interventions or the interprofessional meetings that we had about him. So the first opportunity to do that was at the handover meeting. So this is a meeting we have every morning at 8 o'clock in the morning, our first meeting of the day. It's led by the registrar who is on call over the preceding 24 hours. It's attended by consultants, registrars, junior doctors, nurses, the flow coordinator who deals with admissions and discharges, allied health professionals, so physiotherapists, occupational therapists, a pharmacist, and medical students. Plans are made for the referred patient, and at 8:30 we go on and talk about the inpatients on our ward, which is quite useful to see how many beds we've got and who's coming and going. So the type of interprofessional team intervention the handover is a communication intervention. So it's sharing knowledge across the different professions. It's about crew resource management, so that the junior doctors know that they're the ones to organize the scans, that speech and language therapists might want to get involved with the speech part of it. It's about case management, so putting our heads together to get the best management plan for that patient. Sometimes it's about interprofessional learning, so sometimes opportunities arise to teach a little bit or discuss things and learn from each other. And so the outcome for Mr. S was to admit for the MRI scan, which you saw, discuss at the multidisciplinary team meeting, and to consider an awake craniotomy. Well, there's some problems with the meeting, so quite frequently people go off on tangents and talk about all sorts of other things that are usually totally irrelevant. The focus is on the scans rather than the patient, usually. It's doctor-led. The first row is always the doctors sitting there. It's at a busy time of the day, so there's lots of activity, various admissions needed clerking in, various other meetings to attend. And the outcomes aren't recorded. It's just assumed that people will go off and do their jobs. So the next opportunity is the neuro-oncology MDT. So as I said, this is a meeting on a Thursday. It tends to be led by the neuroradiologist. There's a tele-link with the neuropathologist in Edinburgh. We don't have our own pathologist. It's attended by neurosurgeons, trainees, neuro-oncology nurse. And this type of intervention, again, it's very similar to the handover meeting, but it's focused on neuro-oncology. So it's sharing information, crew resource management, and case management. Again, occasionally discussions are had about looking at various markers or things that we can learn about. And so the outcome for Mr. S is to offer an awake craniotomy with motor and speech monitoring. Again, there's problems with the meeting, very similar to our handover meeting. So it's just once a week, so if the patient is referred on a Friday, we're not going to wait for the whole week just to make a decision at the MDT. Again, it's scan-focused, not patient-focused. Sometimes clinical information is lacking. It's doctor-led, and again, as usual, people go off on tangents and discuss irrelevant things. And some people don't agree with consensus. They don't like it, so as summarized by Lady Thatcher. So in addition to the local MDT, there are overarching governance mechanisms in place, both nationally and regionally. So in 2006, the National Institute for Health and Clinical Excellence, NICE, they advised referral of any suspected brain tumor to a dedicated neuro-oncology MDT. And in the same year, in Scotland, we set up the Scottish Adult Neuro-Oncology Network. And it provides annual reports, it has quality performance indicators, and this also is an interprofessional intervention. It's about integrated care pathways, quality improvement, accreditation, reorganizing care. And this is just the pathway that we use in Scotland for low-grade brain tumors. I realize you can't see it. So then it comes to the actual surgery. So we've not been doing it for that long. So it started in 2010 when I was a trainee in Aberdeen. We had a particular surgeon who'd gone to the States that wanted to bring it back to Aberdeen. And he realized that to do this, he had to have everybody on board. Not just the surgeons, but the anaesthetists and the whole team. And so the whole team went to a course in Germany and saw some awake operations. The speech and language therapists, scrub nurses, neurophysiologists, everybody went. Again, this type of intervention is an interprofessional learning activity. And it's not just education, but it's a team building type of event, which is equally, if not more important. So then we get to the actual operation, or the day of the operation, and we have to go through various checklists. So there's a checklist before induction of anesthesia, before the skin incision, and before the patient leaves the operating room. So this is the World Health Organization surgical checklist, which I'm sure is active in a lot of your practices. So again, this type of intervention is a communication intervention, make sure that everyone's on the right page. And it came about through some work done by Haynes et al., published in the New England Journal of Medicine in 2009. So they introduced a 19-item surgical checklist in 8 hospitals across the world, in very diverse socioeconomic climates. And they found that the death rate dropped from 1.5 to 0.8%. And inpatient complications dropped from 11 to 7%. So really very substantial improvements through very, very simple checklist. the British National Patient Safety Agency saw the use of this and said that it should be instituted in all NHS hospitals by 2010, which it has been. And Atul Gawande was one of the authors in that paper, and he's written quite extensively about that checklist, and if you want further information, it's a very good place to start. And all of this was introduced through the work in the aircraft industry, and it was fairly obvious that the checklists that they've been using for decades could be easily used in the surgical field. Again, there were some criticisms. They thought it might be a Hawthorne effect. That's when the teams improved because of their awareness of being studied. They said that the time out after induction of anesthesia extended the anesthetic time and may lead to, I should say, hypothermia. They said that the pre-intervention rate of death exceeded the published normal range of 0.4 to 0.8%, but it has been introduced and generally has been well accepted. So the patient does get to theatre, gets through all those checklists and so on. And although it's called an awake craniotomy, the patient is asleep first of all. We open the skull and then we wake the patient up. And I think this is one of the most obvious cases of a team working in unison. There's a huge number of people there. The anaesthetist has to get the patient asleep, make sure that the tube is easily removed or removable and can be put back in. They have to anesthetize the scalp. The nurses have to get the positioning very careful because the patient has to be quite comfortable. They have to get the instruments ready. The surgeons have their various bits and pieces to do. The physiologist has his electrical equipment to sort out, to map the cortex. The speech and language therapist has a whole battery of tests to give to the patient whilst they're awake. So the patient gets through the operation very well. And after the operation, he's discussed at our daily board round. We look at all the patients on the board and discuss them with everybody present. Of course, there's daily ward rounds. There's input from speech and language people. We coordinate his transfer back to Orkney. There's a discharge letter made. Discussions had again at the neuro-oncology MDT. And arrangements are made for chemotherapy and radiotherapy. So all of these things, again, you can see the variety of interprofessional opportunities that exist at each part of that. So I hope I've illustrated some of the things that we've done locally in our department in Aberdeen, and I'm quite certain that very similar things are happening at every single department across Sri Lanka as well. But challenges still exist. And so interventions, the changes that we make, often are intuitive rather than evidence-based. The WHO checklist being not an example of that. There's lack of measurement of the impact of interventions, so we rarely test things before and after we make changes. The end customer, if you like, I shouldn't use that word, but the patient and the relatives, their opinions are rarely taken into account. And in fact, it's really useful to hear what they say. You know, sometimes they say the surgeon and the oncologist didn't speak to each other about various aspects of care and so on. So we need to take care of that. And oftentimes interventions lack higher order, rarely tackle higher order problems, such as imbalances in interprofessional relations and inequalities in power. And just to finish, this is a quote. By directing attention towards the need for an educational solution to greater service coordination, it also diverts discussion from the appropriateness or not of existing professional boundaries. So sometimes it's easier to tackle educational events rather than difficult interpersonal problems. But the first picture that I showed you was our hospital in Aberdeen. It's nice to work in a nice environment, but really what makes your working life good or bad is generally the people that you work with, the relationships that you develop, and how the team works as an efficient machine. And so I'd advise you to work on that, and it will pay dividends. Thank you very much.
Thank you, sir. At this time, I would like to invite you to watch a video about IHS. Thank you. At this time, we would like to thank our experienced IT team headed by Mr. Kanushka Martinez for their exemplary coordination of all the presentations to be run smoothly and without any flaws. Without his and his team's expertise, we would not be able to have had our next speaker, who is Dr. Vikrant Bhardwaj, who will be joining us from India on our online platform. I invite the chairperson, Dr. Sankar Randhani Kumara, to introduce him.
Dr. Vikrant Bharadwaj is a qualified physiotherapist with more than 15 years of clinical experience in physiotherapy. He is one of the first physios in India who is doing research and pursuing PhD in the subject of dry needling. He is India's first physio who completed all advanced level in dry needling from GEMT Australia. He is the first Indian physiotherapist who completed certification in MSK, ultrasound imaging, from SMUG, London, UK as well. He possesses experience and in-depth knowledge of dry needling in treatment of various neuro, ortho, sports conditions. He's a member of the American College of Sports Medicine and has represented the country at international conferences and conducted various workshops across India and in Southeast Asia, including Bangladesh, Sri Lanka, Indonesia, Malaysia, and Africa. So his CV goes on and on, about one page, so I would like to, considering the time constraints, I would like to stop from here, and I think we can now listen to Dr. Vikrant Bharadwaj.
Good morning to everyone. Good morning to everyone. Am I audible to everyone?
Yes, Dr. Vikrant, we can hear you. Please continue.
All right. Good morning, everyone, and let me congratulate the people who are sitting here on the dais, on the viewing side. It's a great opportunity for me, and I hope to everyone who's going to participate here, to learn, to listen to the ideas, to the knowledge, as I've heard also since the morning, and it is going to be a wonderful session, as it is since the morning. And I would like to start my talk with a vote of thanks basically to SLMA, Sri Lankan Medical Association, and IIHS, who's really making a great effort to bring Sri Lanka on the map of the world as far as the latest evidence-based practice in physiotherapy, nursing, or other parts are concerned. So here we are. I know the schedule we have a little bit, delayed. So I'm not going to take much time. I'll start it now, and I'm going to wrap it up within the stipulated time. So it is a collaboration between me, my institute, and with IIHS, as I was there multiple times with the institute, and I feel privileged to be there in the institute to conduct a course there in IIHS. And I found one thing, that physios across the workshop were very curious. They really wanted to practice new things, and the curiosity really generated a lot of interest in me to keep coming again and again with the new things. So the content for today's talk would be a little bit about physiotherapy. Or I know there are multiple disciplinary things, people who are sitting across the dais and across the crowd. So I would utilize this opportunity to, highlight few things about the profession of physiotherapy in per se. So physiotherapy, as you all know, who are working in a setup in hospital or in clinics, most of the patients, they come across with post-fractures, stroke, and many other conditions. According to the WHO, if we say, the definition is basically to assess, plan, and implement rehabilitative programs that improves or restore human motor functions, maximize movement ability, relieve pain syndromes, and treat or prevent physical challenges associated with injuries, diseases, and other impairments. So basically, the physios, they apply a broad range of physical therapies and techniques such as movement, electrotherapy, and other techniques that includes the manual therapy also. They may develop and implement programs for screening and prevention of common physical ailments and disorders. Yes, we do play an integral part in multidisciplinary team as we all thrive for one goal, that is to improve quality of life. And of course, we keeps you moving because we are the movement specialists. At different places, we have different roles. We do examine, we do diagnose, we do evaluate, we do provide treatment, and we deal with disability, functional limitation, impairments, and all. And of course, now a lot of new arenas have opened up, like research, administration, and of course in education and academics. I just want to utilize this opportunity to brief you a little bit about this profession. Basically, if you go back to the history, you'll find that the physiotherapy and some of these techniques were used even by the Hippocrates in 360 year BC. A lot of things being contributed by Galen. And then in the modern times, I would say somewhere in early 19th century, the poor Henrik Ling played a very important role in Sweden, and ultimately by 1887, the Sweden Association of Physiotherapy started, and it was recognized as a profession. The whole turning point became when 4 nurses in UK started the Chartered Society of Physiotherapy by dealing the patients with the disabilities. And then the School of University of Otago opened, and different physiotherapy colleges. And somewhere in 1920s, American Physical Therapy Association was founded and started by Mary Macmillan as a Women's Physical Therapy Association, which later became APTA. So this whole concept got gained momentum somewhere around the First World War and the polio outbreak, and then around Second World War, it really paced up. So when we reached somewhere around 1950s, the whole profession moved out even from the hospital setup, and people have started going for OPD clinics and other stuff. By 1974, the IFOMPT was founded, and later on, many things have changed. If I talk per se in last 2 decades, there is a very steep changes in physical therapy practice. Now we are going more evidence-based. We are incorporating more technology. As in many countries across the world, we've even started using ultrasound imaging for not diagnosis, but to execute the treatment like exercises or dry needling and other manual techniques. As a physiotherapy, it's a wide-ranging profession. And just to enlighten and just to remind a little bit about the different branches of this tree, we do have a respiratory physiotherapy where we go in ICUs, we do physiotherapy there. We have neurological physical therapy, we have musculoskeletal physiotherapy, especially in orthopedics. We are doing in pediatrics, we are doing in sports physio, we are doing in ergonomics, obstetrics, and gynae. If I'll come back to the topic which was given to me, it was a role of a physiotherapy in a multidisciplinary care. Multidisciplinary care, as being discussed since the morning by many of our speakers, and very well said about that it is basically when professionals from a range of disciplines with different but complementary skills and knowledge and experience, they work together to deliver comprehensive healthcare aimed at providing the best possible outcome for the physical therapy, for physical and psychosocial need of a patient and their carers. Each profession has a unique importance, and it's a teamwork, as already mentioned by Dr. Aberdeen also. We want that we should have more efficiency, we should improvise. As you all know that the kind of country or the population which we are going to cater in future, if I talk about my country, which is one of the second largest populated country in the world, we have to cater a very large population. So we have to improvise, we have to work in tandem, we have to coordinate with each other so that multidisciplinary work can be done and we can serve better to the patients for better outcomes. This is where I work. It's basically a surgical center, one of the leading brand in India, who are doing a lot of surgeries here. And let me just tell you, share with you, we are working as a big team where the surgeon is there, nursing staff is there, we have physios, we have OTists, we have speech therapists and other people in our team. So I just want to include one example here. As this is what came into my mind when I was preparing this talk. We have regular surgeries of knee replacements. And just to share with you the kind of conversation which we have before the surgery, I'm talking about the surgeons. They send patients to us to basically brief patient what we need to do after the surgery, because they always mention one thing: surgery is just one part of the treatment. If you want 100% recovery, you have to go with different options like post-rehab care, and obviously it's a teamwork. So when a surgery is being done, the surgeon is doing the surgery, the nurses are helping in nursing care, OT technicians are helping the surgeons, and after this immediate surgery from day 0 to day 5, we make patient to stand and move. And if I say, I want to share a small video with you, and the video is here. We make the patient, we bring the patient in this condition, this old lady who's 80 years old, and she is walking, the stitches have not even been removed. And this is very oftenly said by our medical team that surgery will be successful if it will be a teamwork, and every participant of the team has to play their role. All right, so let's come back to the presentation. Yeah. As far as the role of and responsibility of physio is concerned, definitely we are a valuable member and everybody is a valuable member. We promote health, we have to prevent disability, we have to play a role in screening the patients. One of the research done in Canada that showed that just involving advanced physiotherapists in the team, it helped them to screen out the patients who could be treated with the conservative treatment. So the precious time, waiting time for those people who required hip replacement surgeries had gone down. So you can understand the importance of the screening. It reduces the costing, it reduces the time, and definitely we have a role to play in assessment and treatment activities. Apart from the treatment of musculoskeletal conditions, physios are well established. They have a role to play in, treatment and maintenance of chronic conditions like CAD, cardiovascular diseases, COPD, diabetes, osteoporosis, obesity, and hypertension. If you go to the ICU ward, you'll find physios who are working. I can say proudly that in my hospital, we have even night shift of the physiotherapists who are doing their duty, who do extubation, who do postural drainage, who mobilize the patient. And even in the gynae ward, it is mandatory, or in OPS patient by the surgeon, that one has to go under antenatal session before getting ready for the delivery. So this is how we are doing as a team. Then as far as neuro patients are concerned, stroke patients are concerned, we are working in tandem with the neurophysician, with the physician, with the OTist, and we are all trying to get that better outcome of the patient. So I would say that there are 4 C's basically, which are the advantages of multidisciplinary care. It is clinically effective, or in other words, I would say that it is more complete because we are integrating all aspects of the requirement of the patient, whether it is a physician, which is going to cover the medicine part, a physio, which is going to cover the movement part, a nurse, which is going to cover the nursing and the care part. So it is clinically more effective because it is complete. I would say that cost efficient because it indirectly reduces the burden. Like, you don't have to go for surgery all the time. It is going to save precious time of a surgeon and the cost of the country or the insurance or even on the patient, because in many developing countries in India or in Asia, there is no insurance system. Patient has to pay from its own pocket. So if we can do something non-surgical or non-pharmacological, it is going to definitely help the patient. Number 3C is the confidence. It gives a lot of confidence to the patient because patient is going to interact with different people of the healthcare profession in the multidisciplinary team. So the questions could be sorted out well by different members of the team. The last C is the compliance, because there are more checks and balances because patient has to filter through many people. So the compliance is indirectly definitely improves. So it allows a multi-dimensional diagnosis of the condition. It avoids duplications of investigation in many cases. It facilitates early and accurate diagnosis, especially if the waiting time is short. Aids rapid initiation of the treatment following diagnosis. Ensure the availability of wide array of treatment options, whether it is pharmacological and non-pharmacological or surgical. Treatment plans are very much individualized and care is delivered in a programmed and a coordinated manner. It provides continuity of interaction and care. So the treatment offered is up to date, evidence-based, and safe. Treatment failure can be recognized at a very earlier stage. So that's a positive thing. What we need to change, we can do that. Faster return to the work. Patient can have a greater confidence in their treatment plan, knowing that it has been developed by collaboration between different specialties. Patients have the opportunity to discuss treatment options and ask questions of the different specialists involved in the care. And ultimately, it improves interdisciplinary knowledge, the thing which is being shared by even Peter and the earlier speaker, that we need to improve interdisciplinary knowledge. It gives a better communication. So if I want to conclude, I would say that it's an approach to achieve good outcome, and physiotherapist has a definite role to play, just like any other healthcare professional members who are there in the team. With that, I have been not taking much time. Thank you so much for listening to me. I'll be happy to reply to your question and answers, right? Thank you.
Thank you, sir. Now, the moment we all have been waiting for, the interactive session commences. I would like to invite all the participants to access the link that has been sent to your phones and log into the page. If you experience any difficulties, please flag one of the staff and that they will come and assist you. You will have 10 minutes to fill in the questions, and please don't forget to submit your answers. For those who do not have the link, please raise your hands. While you're still filling in the forms, I would like to invite our distinguished speakers back on stage for this session and to join with our chairpersons as well. Can we have Dr. Kitsari Edrisinghe, Dr. Leanne Bodkin, Mr. Peter Bodkin, and Ms. Glenda Whiting, and we have Dr. Vikrant Bhardwaj from India online. Please come up on stage. Thank you. In the meantime, you are free to ask any questions that you may have from the panel. If you have a question, please raise your hand and we will hand over a mic to you. Can we have questions, please?
Hello, it's Navika. I work for IIHS. I'm one of the directors there. Actually, I want to ask something from a Sri Lankan context, and we have many nurses here as well, so I hope you all can answer and support my question. From a very hierarchical point of view, how easy or difficult or what challenges do you see anyone in addressing multidisciplinary approaches in terms of, say, the doctor-nurse relationship? I used to work in ICU in Australia, and it was quite, it was very easy working with a lot of the professionals, and I'm sure it's the same here, but what challenges do you face, anyone, anyone from the Sri Lankan context? What are the challenges that you face when working in a clinical context in a very multidisciplinary approach? Ms. Ashoka?
Thank you very much. If I say frankly, we can observe multidisciplinary approach in some practice areas, but in some practice areas we cannot observe. But I strongly agree with this theme. We should inculcate that in our practice setup, then patient outcome will be very good. So this is the time for think over that, and we have to step forward to achieve that goals.
Thank you. So Ms. Ashoka is the principal of the post-basic nursing unit of Sri Lanka. Any questions from any of the panel or from the audience? Anyone?
It's all very...
What was your question again, Nadika?
My question was actually discussing or asking people about the challenges that they face in a Sri Lankan context when addressing a multidisciplinary approach in the clinical context. Yes. See, there's a lot to talk about.
Huh? In our curriculums, we have less time allocation for these contents. So we should increase that number of hours to have multidisciplinary team approach in care setup. And that means we have to include these concepts in our curriculum. So that is a challenge for us. Though we think to change our curriculums, some hierarchies are there. We have to take approval from the ministry. So it takes long time. So that is a challenge. And some internal barriers may be there, especially lack of academics for trained academics for these things. And furthermore, we should think we should have continuous professional development opportunities. That is also lacking. That is also a challenge for us. We have to do some CPD programs. That is also a barrier. If we try to have some in-service programs, it takes long time, money, material, manpower, everything is limited for us. So that is also a challenge. And finding time to have these sessions also a challenge. Why we are with very much shortage of staff in our care setup. So these are the challenges.
Thank you very much.
Nadika, can I address that in completely a different point of view?
Yes, yes, sure.
I think I was talking to Dr. Kitsiri as well about this thing. I think the problem is with our education system. Because when we are entering into the university, we have sort of a different mindset where we already know that, okay, the highest marks are going to the medical faculty. The next people are going to this, next are this. So this is the problem here, I think, because we have a totally academic-based system where only the academic performance are only the things that are counted for the university entrance. There's no 360-degree evaluation. So we are, in certain people go with an inferiority complex, and certain people think they are superior. So this is the problem we have, that I think in our context in Sri Lanka, that we have, it's a barrier for this multidisciplinary or the interdisciplinary collaboration. I'm from Faculty of Medical Sciences, not a Faculty of Medicine, Sri Jayawardhanapura. So we worked with nurses, BSc nursing students, B.Pharm students, and MLT students, BMLT students. So we know how friendly we were. So that same spirit is going along and along in our probably our profession, in our day-to-day activities. So I think this is most important. I think we need a system change. We need education system change, especially where all the people, because we always think some professions are superior and some are not. This is totally wrong approach, and everyone should think that everybody is having some sort of a responsibility, and all the professions are same in the sense they are respectable. So that's my point of view.
Thank you very much.
Okay, thank you for giving this opportunity. And I think it is my idea also similar to Dr. Sankar's idea, but it is very much of our attitudes affecting on this multidisciplinary or interpersonal education development, because we work together, and when we are training our nursing students, other professionals also coming to teach them, but when we take to student, they are not like to sit in same class to learn in different aspect, but they have some as doctor said, superior ideas and other things. Yes, it is true, it is according to our education system, because our student does not have to chance to select what they like, but according to their A-level marks, the university is selecting, sometimes they can apply what they want, but most probably they are selecting according to their marks. Then they have some superior ideas when they enter into the secondary level education also. That idea is going throughout the system, and very difficult to change that attitude also. Now in our, when we are junior nurses, there were some environment in interdisciplinary or collaborative practice, but gradually now it become more broader or more distant within the professionals. But doctors or consultants come to the ward and doing ward round without talking to nurses or any others, and nurses also go behind them. Likewise, this is our environment. But I think there should be a good attitude change also when we are practicing this multidisciplinary or interprofessional education. But as this is the way that we have to educate our student or our professionals to get the maximum outcome of the patient care. Thank you. Thank you.
Thank you very much. Moving on, the results of the interactive session are ready. So can we have the first slide? So in our audience, we have from different professions, and that's the spread, and we also have from the private and public sector. The first question, multidisciplinary healthcare means merely having professionals from a range of disciplines. And those are the answers, and I'm going to hand it over to the panel for discussion with the audience.
That's better. That's better. I had it off before. So the majority has agreed that multidisciplinary healthcare means merely having professionals from a range of disciplines. Is that correct? Yeah?
Yeah, right.
Don't you think it means a bit more than that? What were the other choices?
There are some who have said it strongly disagree. I would like to know what their opinions are if they strongly disagree with this. Anybody wanting to volunteer a response as to why they disagree with it?
From an educational perspective, I think it's a badly written question because the word merely in there straight away makes you think that there is another underlying layer to that question that is to get you to think that it's quite possibly not a straightforward answer. Anyone willing to admit to being disagree or strongly disagree? And why they chose that?
Some ideas are there in that question. Merely having professionals means some might have thought that other non-professionals should be included. That's why strongly disagree and neutral option.
I think that's a very, very intelligent response, yes. We may not, for example, sometimes consider maybe bringing a priest or somebody from, what we call a faith background into the team and consider them a professional, although they are professionals on their own right. So, as you said, maybe the question may be somewhat ambiguous in terms of its focus. But anyway, we got the majority saying that they agree or strongly agree. So I think that question is settled.
Moving on to the next question. Effective transdisciplinary healthcare requires integrated interprofessional development and education.
Yeah, I think we're all agreed on that one.
Okay, we'll have the next question. Next slide, please. If you meet a member of an out-group who does not match the stereotype you hold for that group or profession, you will assume they're a typical member of a profession and maintain your stereotype intact. Change your stereotype to accommodate them and apply to all members of the profession, or change your stereotype to accommodate them but not apply it to all members of the profession, and maintain your stereotype and ignore the evidence from this individual.
I don't Is it on? You could probably guess this was my question. I'm quite pleased to see the spread of answers because it was a trick question. Really, one of the issues is that any of those things can happen, except possibly for the one where you don't apply it to other members of the profession, because actually that's what a stereotype is, that you apply it to all the people in that group. But what we hope for is that transformation, that you can have a positive change and apply that to the group. But there is a risk that you can have a negative impression of another member of a different profession and apply that across the group. So there is some inherent danger in doing multidisciplinary training and education, in that it doesn't always go the way that you had hoped that it would go. And that really comes back to some of the comments that were made about the barriers. So really what you want to foster is environments where there is a good collaborative practice already, and use them as role models and to facilitate learning in those kind of areas where there is already that good role modeling that you can pass on to others. If you put students and professionals in areas where there isn't good collaborative practice and you role model hierarchies and problems, then that can then get perpetuated. So it's to be aware of the environment that you're trying to bring in multi-professional or interprofessional learning into.
Thank you. Next slide, please. Drivers for interprofessional learning in practice.
Do you want me to read them?
Please.
Except it's a bit close, but real and relevant, patient safety, improve patient outcomes, improve staff morale and retention, reduce complaints, and collaborative practice. So the drivers for interprofessional learning and practice. Everything scored, didn't it? I'm glad the improved patient outcomes gets the largest. Certainly patient safety, certainly collaborative practice. And I mentioned about the staff morale and retention, more job satisfaction from that intercollaborative approach. Hopefully reduce complaints, that would be nice. Anyone else? No? No? Good.
I think basically it's a representation of the priority of all these different things. Yes. So I think we've got the first three right. I think in terms of priority, we got the order right here.
Thank you. Next slide. What is the Hawthorne effect?
So is when there is a bias due only to selected group being studied, is not possible in papers where the patients were not aware of being studied, is a type of observation bias, or can usually be easily eliminated from a study.
Yes, so this is my question, and it should be the third one along. So it's a type of observation bias. So if a team knows that it's being studied, it can actually change its practice without necessarily adopting the benefits that were assumed to be in the trial. It's very hard to eliminate that from papers. And even if patients know that they're being studied, that doesn't necessarily change things. It's perhaps if the doctors know that they're being studied. So it's not necessarily the patients. So C.
Okay. Thank you. Can we have the next question? Interprofessional intervention should take the patient's family's opinions into account.
So again, that's my question, and I'm very glad that you agree. So as I said, it's really useful. We kind of assume that we discuss things between ourselves as professionals, but we also have to link in the patient's ideas of things. And sometimes we don't really see the problems that the patient sees. So for example, discussing diagnosis from a surgical point of view, we may not discuss things with that patient if they have a brain tumor or something, and then they go on and see an oncologist, and they are told a lot about their diagnosis. And the patient may recognize, a disconnect between the two. There's not been proper discussion, which we didn't recognize. It's important to speak to the patient.
Can I just add to that as well from an interprofessional learning point of view? Patients can be huge advocates. So when you're facing barriers, actually the patient voice can be a huge advocate for encouraging interprofessional learning amongst teams, because they can highlight where they have experienced good practice of teams working collaboratively together, as well as when they have been aware of lackings where colleagues haven't worked together well. So the patient's voice can actually be a really strong and valuable driver to encourage change.
Thank you. Next question. Interprofessional working interventions should be evidence-based.
I think that's a straightforward one.
Next one. Male nurses are not allowed in the labor room.
Yeah, moves towards the more of a negative side. I would like to know from the audience, Eddie, any thoughts on that?
Dr. Kitsiri, when I went into obstetrics, I was a male. I'm still also a male, and I think I had very good acceptance. So,
I suppose the question is a bit about the perception of the role, and that the role of a nurse versus the role of the obstetrician or the doctor in the room is somehow different. And that's why there, along with that goes expectations of gender and approach and other things. So it's quite a loaded question, I think, actually, because it gets to the heart of what it is to be a member of that profession and what that means. I don't know if we have any male nurses in the audience. It would not be accepted, is that what you're saying? Culturally not accepted, yeah, absolutely. So it's quite complicated in the cultural context, isn't it? Sorry.
In this response, we can see many of them are agreed to allocate male nurses in labor rooms. Actually, up to now, some cultural, I cannot say misconceptions or something, somehow male nurses are not allowed to work in labor rooms up to now, but I think nursing means caring. So wherever they work, they can do their caring part for the consumer. So I think this concept should change. Male nurses also can work in labor rooms and they can provide necessary care. So this response is okay according to our points of view.
Majority of the audience, you know who they are.
Thank you. Can we have the next question, please? Nurses or physiotherapists should not carry a stethoscope.
Obviously, the large part is sitting around the strongly disagree. Is that about the person carrying the stethoscope was always the doctor? Maybe? That we always thought about that, and a nurse or a physiotherapist would never use a stethoscope? Personally, I don't find great difficulty taking a blood pressure without a stethoscope. I'm a midwife. I actually need pinards or something like a stethoscope to listen to a baby's heartbeat. Yeah? So I think that is another one of those sort of questions around that perception of how you identify people, and you identify the stethoscope with the doctor perhaps. So I'm glad you all disagree, because otherwise you need to show me how you do blood pressures without one then.
These are the differences that we have. I would call it as a misconception. It's a role of the profession versus the functional role of that particular person at the patient care process. I mean, we have concepts. We developed the doctors, the concept of a doctor with a stethoscope, concept of a nurse without a stethoscope. Now, times have changed. Times have changed. Technology have changed. The procedures have changed. How on earth a physiotherapist could do chest physiotherapy without a stethoscope. I mean, you have to be a miraculous, some spiritual guy who can come and listen to all that, and similar to you, what you said. So things have to be changed. There's a massive gap between our perceptions and what has to happen. It's a good argumental point, but still there's load to. This shows that we are quite away from the modern world, though we use modern technologies and the equipments and the facilities.
Could we have some feedback from Dr. Vikrant, please? From a physiotherapist point of view. Just a minute, sir. Just a minute.
Me now?
Yes, sir. We can hear you.
Okay, I just want to add here something what we are practicing in my country. A physio or a nurse, it is almost a sort of a mandatory that they are carrying it, especially when they are dealing with either in ER or in ICU or in casualty, because it's a part, it's just like a gadget. So I think there are more of mental blocks which we had inherited in the era of transformation of whole healthcare services. And now things are quite changing. I still remember that when I started collaborating with my radiology, this is something, not related exactly. I just want to quote something here, that in my hospital initially, we got a little bit resistance from the radiology department. Oh, somebody from the physio background, they are going to use an ultrasound machine. But ultimately, we got collaborated, we cleared the doubts, and it has been found that there is nothing is somebody's territory or something we are invading. It is more like we are doing for the better outcome of the patient and to serve humanity better. So I would definitely disagree with this, and now things are changing.
Sir? Next question, please. All should wear scrubs, comfortable clothing in the hospital. That means all professionals, all medical professionals should wear scrubs.
The question was posted by me. Simply, this is all to do with what I said a couple of hours ago. Now we are in a battlefield. Of course, the army or military would use their uniform in ceremonial occasions only. But for the battle, they have a different battle. They have a different uniform. And today, if you look at our medical professionals, we are expected to, especially the females, they're expected to wear saris by mandate. And then our nursing uniform is extremely nice. It's beautiful. But how useful that is in your work with this humidity, the patient loads. Things have changed. The temperature has gone up. And it's extremely uncomfortable. This is what it is at the moment. And there's time that we have to really look into our professional bodies and start discussing these things. And why not we do a survey? I haven't seen a single survey on this. I stimulated one in the Facebook some time ago when I was in Aberdeen. I met there are two wonderful nursing officials. They manage the second and the third year. All the clinical programs are conducted by two nurses, all the universities. So I posted with them posting, and then I said, what about our uniform? Then I got, I think, about over 1,000 responses by all the nursing professionals. Still the argument is going on. I still see the postings going on. So this is where we have to have a evidence-based approach, have a survey. I would like to have from the audience as well. And what about Glenn? What do you think? How has it been evolved in Australia?
The uniform certainly changed. When I trained, we wore, as you did when you were qualified, you wore a white dress, and it was almost a badge of honour or a reward that you got for all the years of training. You got to wear the white dress. But it's very impractical wear, and we in a hot country as well. And I know all of you, even the other nurses who have got white aprons, they get very dirty and things happen to you through the day. I'm a midwife. Imagine what I look like by the end of my day. And that might have just been on the ward with people breastfeeding and babies doing other things. Anyway, I personally am not a big fan of scrubs. I think scrubs are for the theatre area, and we obviously wear them. We used to have to change into scrubs in labour ward. We don't do that anymore. But I certainly think there's a wide range of uniform that are appropriate, and in the modern environment, to be able to wear something that you can move better in, so that you don't injure yourself when you're trying to move patients or do those sorts of things. So most people where I work would wear trousers, not wearing a dress anymore, so that you're covered more. It's much easier, and our shirts are obviously much easier to move about in. And we no longer have things on our heads, except for our hair. And when I trained, we had caps very similar to the nurses sitting here, which we then got stripes on for every year of our study. And then supposedly when you graduated, you took them off and put on a veil. And I just never really wanted to do that. So quite fortunately, that all changed just as I graduated. I didn't ever wear a veil. And I know my mother was really upset that I didn't get to wear one, because I think she thought that was the pinnacle of things to do. So, you know, the 30 years that I've been nursing, things have changed quite a lot. And there's all of that. When I first started, we had to wear plain clothes to work and change into our uniform. We weren't allowed to leave the hospital in our uniform. That's gone by the by now. And the modern infection control principles and things, you know, there's demonstrated evidence around that, you know, the benefit of not wearing a uniform there, and whether you wear scrubs or not wear scrubs. I think probably my thing about scrubs is that they're a bit pajama-like, really. And they can be very casual for the ward areas, but that's just my opinion. I don't know, you guys might have different ideas.
I would like to add a few words to that. In the United States, in the hospitals that I worked, in the pediatric wards, it was almost mandatory that the nurses wore something very colorful, something that looked jolly, maybe which had pictures of balloons and flowers and other little, you know, teddy bears and stuff like that, to reduce the level of apprehension on the part of babies, our children. Yeah.
I think the patient's perspective from a child there, but from all patients, is quite important here, because one of the roles that the uniform plays is it tells people what profession you are. And one of the complaints from patients where in departments where everyone looks very similar is that they don't know who is who. And when you ask them, you know, who have you spoken to about this, they don't know whether it was the nurse or the doctor or the physio or a nursing assistant. They haven't actually got the kind of visual reference for that. So it is still important to think about, from the patient's perspective, how they can understand who it is that they're interacting with. So that has to be taken into account from that point of view.
We could have a show of hands to see who agrees that scrubs or something similar should be worn. So who agrees with that? So you want to stick with your... well, I suppose, yeah. I see, yeah. Okay.
How many of you would want to change from what you're in now? Go on, I won't tell anyone, just put your hands up, go on. Yeah, everybody. Whoever's in charge of this, everybody wants to change. Yes? Yes, I agree. Uniforms, I think, as you've said, are very important to be able to identify with. I think there's a certain pride that's associated with the uniform, because that identifies that I'm a nurse. And in Australia, every single hospital has different uniforms. So even within the public sector, every hospital would have a different uniform. So I could tell you that that nurse works at the Royal Adelaide Hospital, that nurse works at the Flinders Medical Centre, still employed by the same public health system, but they've got different uniforms. So there is a sense of pride and identification around where you work and what you do. But I'm very much in favour of having uniforms. I think it's a good thing to do. And it does certainly help the patients identify who you are. And you've earned it. All that study, you know, you want them to know you're a nurse, don't you? Yes, we don't want them to think we're doctors, we're nurses. We want them to know that.
Thank you very
much. Add something?
Sorry.
few years back, I did a research actually about the patient's or client's perception. Interestingly, they think that the female doctor should wear the sari and the male doctor should wear the tie. So I think we have to change the attitudes as well.
Thank you very much. Can we have the next question? I would think that's meant to say all multidisciplinary professionals should share the nurse's station.
Any thoughts on that?
I had a little difficulty with the word nurse's station because if you have medications and stuff like that in that area, I don't think I want other people to come there and put their fingers into it. And that's a sacred area and a very critical area at that, unless I'm mistaking nurse's station with the medication cabinet as separate entities.
When you look at the state sector, I'm kind of supporting on hospital designs. So when you go to a typical state sector, we have different units. We have a doctor's room, we have a consultant room, we have a nurse's room, we have an in-charge's room, and each one of them will have toilets. So recently I looked at a building plan of I don't want to mention the name. 30% of the hospital is allocated for these rooms and the toilets, the whole building. So this is simply because we couldn't share a place, even the toilet. Okay, you might have culturally we wanted separate ones. But the whole idea of this question is, can you sit on one place and work together? Any thoughts on that?
Well, I guess it'd be nice to hear from the audience to see what you think.
According to the workload, the separate phases may be there, but when they want to get together for any decision making or any essential matter, they can get together in same place. Not nurses station, I am also not agree with this station, not only nurses. Anyway, the place may be another term. They must get together when they want to get together for decision making for the sake of patient care. That is my idea. Okay, thank you.
Yeah.
Okay. Thank you. Can we have the next question? It's not necessary to have a case board, multidisciplinary meetings.
So most people disagree, or strongly disagree. So it's most people think we should have case boards, MDTs. But there was a smattering of people that said that agreed and strongly agreed. Yes, it may be in the wording, perhaps. Okay, I think this is a fairly clear majority for disagree.
Okay, thank you. Next question. Medical, nursing, and physiotherapy students should share few classes together.
Looks like most people agree with that. It's probably also worth mentioning, though, that the research shows that contact is not enough. Just sitting in a theatre as you are here, you are an interprofessional audience sitting here together. That doesn't mean that's going to improve collaborative practice. And as was mentioned, I think by one of the chair people and by Glenda, that it's actually the friendships that develop, the conversations that happen, the relationships that are built that are more important than the fact that you're physically sitting in the same place together. So even talking about a ward station or a nurse's station to have those decisions, it's not the place, it's what happens and the interactions that take place together. So it's actually active engagement in that. You could all be sitting in here still in your isolated professional way and not
collaborating with the people around you. So contact alone is not enough.
Thank you. Next question. During their internship, medical students should be trained under nurses and physiotherapists as well.
I'm not sure that was my question, but I think in my question I had the information more about that they're working together. Is that right? So medical students should be trained under nurses and physiotherapists as well. I'd say perhaps alongside. I don't know about under. Is that more the point? And there is definitely an agreement around that, and that was about that collaborative practice and working together. And I think I mentioned about that extension of when they actually go into clinical practice, that you know then people in the clinical practice, so that you're working more together in that when you're on placement and those sorts of things as well. So.
Just taking the point of under, because that's the question that people answered and people agreed with. Maybe that comes back to the question of hierarchy. So actually you're saying that the expertise and knowledge held in each profession is as valuable as that held in another. And actually it is incredibly valuable for a nurse to teach a medical student what the experience of a patient is, having a procedure in the ward and everything that goes along with that, because actually that is not information necessarily held in the medical profession, it's actually held in another profession. So I think there is a huge value in recognising the expertise that other professionals have and allowing opportunities for that to be shared with training of other professionals, so that we actually value that expertise and knowledge from the other professionals from an early stage during training, and say that yes, nurses can teach medical students and physiotherapists can teach medical students because they have different things to add to that experience.
Thank you. Next. What are the major causes for medical errors?
Just so you can't see around me. The one that had the most responses was communication issues, technical failure, inadequate policies, relationship issues within the team, and lack of training. So the majority was communication issues, then relationship issues within the team, and lack of training.
Okay, thank you. Okay, so this concludes the interactive session. Thank you so much for participating. I'd like to thank our speakers and the chairpersons for their valuable input. And we will move on to the next event in a minute while we ask you to join the audience. At this time, we would like to show our gratitude and appreciation to all our distinguished speakers. I kindly invite both our chairpersons, Dr. Nihal De Silva and Dr. Sankar Randhani Kumara, to give out the tokens of appreciation, please. So our first speaker, Dr. Leanne Bodkin. Can we have both chairpersons in the middle of the stage, please? Mr. Peter Bodkin. Ms. Glenda Whiting. And for Dr. Vikrant Bhardwaj, who is joining us from India, Dr. Vikrant, we'll be sending you over your tokens. Thank you for joining us. Moving on, Dr. Kitsari Adrasinghe. Thank you. We would also like to extend our gratitude to the chairpersons of the pre-Congress session. And to give out the tokens, I kindly invite Dr. Kitsari Singha, CEO, co-founder, Direct Academics at IHS, to give out the tokens, please. To Dr. Nihal De Silva. And to Dr. Sankar Randhani Kumara. Thank you, sir. As the pre-Congress session comes to a close, I would like to invite Dr. Dinusha Kanatiwala, who holds a PhD in microbiology and is an honorary lecturer for the School of Medicine, Medical Sciences and Nutrition at the University of Aberdeen, UK. She is a senior lecturer in biomedical sciences and also the deputy head of the academic department at IHS, and she will be delivering the vote of thanks. Dr. Dinusha, over to you.
Thank you very much, Miriam, and good afternoon to all of you. It gives me great pleasure to propose vote of thanks at the end of this very productive session. First of all, let me thank Sri Lanka Medical Association SLMA for providing us the opportunity to host a session at their 131st anniversary International Medical Congress. I also thank Dr. Nihal Silva and Dr. Sankar Randhani Kumara, chairpersons of the session, for spending their precious time with us today. Next, the resource panel of this session deserves a very big thank from all of us. Thank you, Ms. Glenda, Dr. Leanne Bodkin, Mr. Peter Bodkin, Dr. Vikran, and also Dr. Kitsari Adrasinghe for your inspiring presentations, which were very informative. And also thank you very much for your contribution for the interactive session. I cannot forget the special guests who were with us today for taking their time out and spending the day with us. Especially, I would like to thank President SLMA, Dr. Hanifa, the Secretary, Dr. Hasini Bannaheka, for honoring us with their presence despite their busy schedule. The audience, they deserve a big thank. Your active participation, especially during the interactive session, made the day very colorful. I'm very much happy to see this auditorium full of participations from various disciplines. Thank you very much everyone for taking part and their contribution for the session. Let me finally thank the team IHS. Firstly, our CEO, Director Academics, Dr. Kitsari Edrisinghe. Thank you, sir. He is the pillar behind us. Thank you very much for your guidance and support given to us. The directors of the company, Ms. Stephanie Anthony and Ms. Nandika Jayasinghe, thank you being exceptionally helpful from the very beginning. The scientific committee of IIHS, especially Damit and the team, Mr. Damit and the team, they are the ones who designed this interactive session. They deserve a big thank from everyone for making this interactive session a very great one. And also the members from scientific committee, thank you kids, you made everything easy for us for helping out with all the arrangements. Next, all my staff colleagues at IIHS, this time Ms. Apsara and the team led the entire organization, and also Mr. Kanushka and the IT team. Thank you very much for your hard work and the dedication shown during last couple of weeks. Finally, let me also apologize for not being able to thank you by name. There were many people who were behind us to make this conference or session very successful. So once again, thank you very much everyone and have a nice day. Thank you.
Thank you, Dr. Dinesha. Well, this has indeed been a very successful event, all owing to the multidisciplinary team that has put everything together. And obviously, it's a very good example of what a multidisciplinary effort can do in bringing success to anything that you put your mind to. Moving on, we are going to conclude the proceedings for today. We have prepared an e-certificate for you, signed by all the distinguished international panel, for which you can download from the website and print it out if you wish. We would like to invite you to join us for lunch. The organization committee will direct you to where lunch is being served. And before everyone leaves, we would like to take a photo. So for just a few minutes, could you be seated while the cameraman gets the photographs? Seated? Smile, please. Can we have everyone on their feet, please? Can all those seated on the wings of the auditorium please move into the middle? Can we have the chairpersons also in the audience, please? Thank you.